All right. Okay. Okay. All right. Good afternoon, everyone, and I hope you're having a nice day. I'm talking to you from West Coast. I'm in California right now. I'm at Children's Hospital, Los Angeles. I'm one of the neonatologists here. I work in a level 4 NICU, and today I'm going to be giving you a couple of lectures. I figured it's the beginning of life, you know, the newborn, the first breath. And it just makes sense before we talk about the different pathology of the neonate. Just to give you a little bit of a background on lung fluid, the fetal fluid, the lung fluid, as it affects the transition of the baby from being in utero to an air-breathing individual. Okay, so please let me know at the end of the talk for questions. No interruption in the lecture. We'll just proceed with the rest of the talk, and then I'll allow some time at the end for Q&A before I move on to the next topic. All right. So TTN, or wet lung disease, transient tachypnea of the newborn, as the term implies, you know, the lungs are wet. They're still filled with fluid, but it's a matter of degree. Okay, so it doesn't present uniformly across the board. Some babies have very mild forms, some babies will have severe forms, but to introduce the disease, we have to go over the concept of how the fetal and neonatal lung fluid evolved and resolved. Okay, so these are the objectives of my talk. So we will review the transition of the fetal lung fluid from being a fetus into the neonatal lung, and then we'll proceed with the clinical presentation of TTN, the pathophysiology, the differential diagnosis, meaning what other conditions you will think of when you have a baby with those presentations, and then how we manage TTN patients. So the formation and removal of fluid in the fetus goes through a sequence of events. Okay, we'll start with how fetal lung fluid is secreted. As you all know, the fetal lung fluid is very important in fetal lung development. So if there's no amniotic fluid, I mean, that's another contributor of fetal lung development. So the composition of fetal lung fluid is very different from that of the amniotic fluid. They're two different fluids. They don't connect to each other, okay? And I'll tell you how we can measure fetal lung maturity by looking at the amniotic fluid a little bit later, okay? The baby, the fetus, should have a decrease in lung fluid before birth in preparation for delivery and labor. Women who labor before they're giving birth vaginally to their babies already incorporate that decrease in lung fluid before the neonate is born. Okay, there are certain hormones that affects the production and absorption of this fetal lung fluid. And the lung fluid clearance is not complete prior to birth. It will continue after birth, minutes to even hours. So it's very important that we know how this particular pathology presents, and we can understand the evolution and then resolution of the disease. Okay, as I've said, postnatally, when the baby is born, fetal lung fluid clearance continues until it's fully resolved, and then we'll review the pathways for the fetal lung liquid removal from the lungs. Okay, so again, just as a quick rundown of the composition of this fetal lung fluid. The fetal lung is the source of fluid that fills the lung during development. It's not the amniotic fluid. As I mentioned earlier, the amniotic fluid has a different composition from fetal lung fluid. And I'll give you a couple of differentiating components that distinguish one from the other. okay? The fetal lung is active physiologically because the fetus breathes inside the womb. Fetal breathing is a measure of how healthy the fetus is, okay? Metabolically, it's important because the lung will produce surfactant, and then the liquid that's rich with surfactant will fill the potential air spaces in the lungs. So when the baby is born, baby takes the first breath, it stabilizes the potential air spaces, so there will be no atelectasis that you see in RDS or surfactant deficiency, okay? Now, intrauterine lung growth depends on the balance of this adequate production and controlled drainage of this fluid in the air spaces of the lung. So if a baby is born from a mom with no amniotic fluid, like in oligohydramnios, then there will be um, a derangement in how the lung of the fetus develops and matures. To the point that it can lead to pulmonary hypoplasia if there is severe deficiency of amniotic fluid. And then after birth, the baby switches from, pulmonary physiology switches from placenta to the baby's lungs that will require the removal of this fluid from the lumen of the lung. So breathing will be a little bit more not labored, and resolution of the signs and symptoms of TTN. So in kind of like a cartoon, this is what happens. You know, you on the fetal lung diagram here, or figure, that it's dark because it has a lot of liquid. And when the baby breathes, the direction of fluid is towards the mouth. So the direction of the arrow is up there, meaning the liquid in the air spaces will eventually make it into the amniotic fluid. So when they measure the fetal lung maturity, they're actually measuring how much phospholipid the lungs have developed. So premature babies will not have much phospholipid, which is a component of surfactant. Okay, so that's how they measure how mature the lungs have become. So during the newborn period, the air fills with fluid, with air, and kind of prepares the lung for normal breathing. So some of that fluid have already been absorbed, okay, during labor, and then during lung expansion. And then postnatally, you can see the lungs are well expanded, and the rest of the liquid absorption will proceed in a normal fashion. So the concept that is often misconstrued is that, well, vaginally delivered baby will have less lung liquid because if it's a vaginal delivery, the vaginal squeeze of the chest will expel some of that lung fluid. But this is too simplistic. It doesn't work that way. You cannot squeeze the chest of a newborn to expel all that liquid. About only a third of the liquid in the airway might happen or might be removed this way. Majority of it is already being absorbed during mom's labor in preparation for birth. Okay, so if a mom didn't go through labor, then the baby still has a lot of lung liquid that will affect breathing thereafter. Okay, so the transition from liquid, which is intrauterine, to air inflation after delivery is becoming significantly more complex. If you compare the lung of fetal lung fluid of 3 scenarios, where the one, if you see my cursor, the one on the left bar with cesarean section delivered baby, this is an experiment in rabbits, and the mom did not go through labor. There's a lot more fluid and the lungs are more wet, so they're heavier, okay? Now, if that mom went through labor and still delivered by cesarean section, the lungs are less heavy. They're not as wet, as you can see from the middle bar here. And then the vaginal delivery, that means there was labor before vaginal delivery happened. They're not as wet as the one with C-section with no labor, but still the vaginal squeeze of the during vaginal delivery, these two here, the middle and the right bar, are statistically insignificant. Okay, so this shows that of course normal vaginal delivery will add an extra help, but it's actually the labor that helps clearance of lung fluid. Okay, so secretion of fluid and lung growth is very important. Like as I've said, conditions with decreased lung fluid, such as when there's oligohydramnios, or when situations where there is diaphragmatic hernia, because on the side where the diaphragmatic hernia is, that lung is not going to develop normally, and there will be a component of pulmonary hypoplasia. Okay, and when there's pulmonary hypoplasia, the lung volume are diminished, and along with it will have decreased fetal lung fluid as well. Not necessarily decreased surfactant, because those babies may be mature upon the time that they're delivered, like in diaphragmatic hernia. Okay. So this diagram shows how fluid goes into the airspace. Okay. I encircled here what I call the chloride pump. Okay. Cl minus. Fluid from the blood, the microcirculation, there are a lot of gaps where liquid will go into the interstitial space. But through this chloride channel, fluid, along with protein, and I'll show you the composition of this fluid later, the interaction, the direction of fluid shift will be from the interstitium to the airspace to eventually fill the airspace with liquid. And that helps with lung development, okay, with fetal lung development. So this potential airspace fluid is rich in chloride, because the chloride pump pretty much takes care of that, and chloride goes with it. So if you measure the lung fluid, the chloride the concentration is much higher in the airspace of the lung compared to the serum in the blood, because it's against an electrochemical gradient. Okay. So this electrochemical gradient across the lung epithelium has what they measured as a -5 millivolt due to the active chloride ion secretion. And this is just, again, in cartoon how that works. This is the ENaC, where the sodium channel, and then chloride goes into the lumen or the airspace. Okay, and there's the interstitium here. And then these are the chloride channels. Again, in a simplistic format, fluid shift follows the chloride going into the lumen from the interstitium. So the chloride enters the epithelial cells, both type 1 and type 2, through the basolaterally located sodium and potassium chloride co-transport and ATPase, the sodium pump. Okay, this is an energy-dependent process which increases the concentration of chloride within the cell so that it exceeds this gradient. And then the resultant extrusion of the chloride through the anion through the apical membrane leads to the shift or the flow of fluid over there. Also, along this paracellular pathways between cells are what we call water channels, we call aquaporins. We're not going to talk about this, but they are relatively active, but the more premature the baby, the less aquaporins there are, so there are fewer water channels that will be involved in this fluid shift. Here's what I was mentioning earlier. If you look at the chloride concentration of the luminal fluid or the air space fluid, it has so much chloride that if you look at the plasma, it's not even close. Look at 107 versus 157. It's because of this chloride pump that triggers the flow of fluid from the interstitium to the airspace. And that's what drives the fluid there, okay? And then when it's time for the baby to be born, the resolution of fluid, the reverse will happen. And I'll show you another figure a little bit later, okay? Also, along with chloride, the protein is also massively different. The luminal fluid in the airspace has very little amount of protein compared to plasma, okay? So if you think, you know, water follows protein as well, but it's the overwhelming effect of the chloride pump that predominates over this shift in the oncotic pressure due to the protein. So the composition or concentration of chloride in the fetal lung, therefore, is 50% more or greater than the plasma, as shown by those numbers, okay? But the sodium concentration is identical because chloride is independently shifted from the sodium, okay? Before birth, the effect of labor becomes operative, okay? Meaning, as labor begins, liquid clearance begins as well, okay? So the rate of lung fluid production and volume of fetal lung lumen decreases before birth, most notably during labor, and the water in the lung, which is 25% greater, I'm sorry, it's a lot greater in preterm compared to full term because, as I've said, the aquaporins are not as mature as they are in full-term baby, or they're not as developed. So in reality, the preterm baby's lungs are much heavier or much more loaded with water compared to term. And their rapid improvement is based on how fast they diurese and get rid of body fluid water, okay? And that includes the lung. So the lung liquid then, after cesarean section without labor, is significantly greater than when delivered vaginally or after cesarean section after the onset of labor, as demonstrated in the previous slides. This is just a summary of what we just talked about, okay? Again, decrease of lung fluid before birth. Again, just to measure, just to show you how heavy the lungs are in fetuses without labor compared to fetuses in labor and those who were a few hours after birth, more fluid clearance occur, and then the lungs start to get more, less weight, okay? And these are experiments in lambs. There are a lot of animal studies that support these physiologic changes. So before birth, they also look at frozen lungs in fetal lamb, and they showed that the result of a decrease in fluid volume of potential air spaces relative to the interstitial tissue volume, there's a reduction in the lung water from 15 to 6 milliliter per kilo. And this is clearance from the potential air spaces soon after birth to allow for effective pulmonary gas exchange, okay? So this is evidence from lamb studies that almost by 2.5-fold that this is the reduction in the weight of this these lungs due to clearance of lung water. Okay, the picture on A shows that the air spaces are larger because there are a lot of fluid, and then B after birth shows that a lot of that fluid has already been absorbed and started to clear, and therefore there's a lot more septations that are clearer here on B versus A. So going to the hormones, what affect the production and absorption of fetal lung fluid? Okay, now during birth itself, epinephrine, which is a beta-adrenergic agonist, and cyclic AMP, the release of these are associated with birth that stimulate the sodium uptake by the lung epithelium, which drives fluid from lung lumen into the interstitium. So this time, the clearance is the direction of the fluid shift in the reverse. And this can be triggered not just shutting off the chloride pump, but it's also the secretion of these different hormones like epinephrine, okay? And then the lymphatics and venous circulation will take care of the clearance of the fluid from the lumen to the interstitium and then back into the circulation. Even thyroid hormones and steroids like cortisol also stimulate early maturation of this epinephrine-induced absorption of lung fluid, okay? So a few hormones are, and that has been shown in pig lungs, that this phenomenon is operative. Additionally, the interaction of these multiple hormones, not just single hormones, play a key regulatory role in converting the respiratory epithelium from a predominantly chloride secreting membrane into a predominantly sodium absorbing membrane after birth. Then this drives fetal lung liquid clearance. Okay. So at birth, these glucocorticoids may upregulate expression of sodium and K, ATPase, and sodium channels, and the aquaporins in developing rat lung. Okay, and this is another important concept when it comes to premature babies who are threatening to be delivered. Um, uh, they use antenatal steroids not only to upregulate surfactant production, but also to regulate some of this lung fluid clearance as well. Okay, steroid does not upregulate lung development in the form of structural development, but mainly in how these processes uh, occur to open up a good setting for lung expansion and better ventilation after birth. Again, this is just a review of what we just discussed earlier, and the reverse now after birth or at birth. Look at these channels. The chloride pumps are shut, and then the sodium starts to get absorbed, and water follows it. And then this paracellular chloride and water goes through these paracellular channels where aquaporins are, and then the water gets back into the interstitium to be cleared. Okay, so this ion transport are increased at birth through these hormonal switches. This is more of the same. The chloride secretion switch to sodium absorption in the lung epithelium near birth and after birth, and this progresses and continues to get better with time. Okay, so just to summarize quickly, this postnatal clearance of fetal fluid, the two components really are the transepithelial flow fluid from the lumen to the interstitium, and this is followed by flow fluid from the interstitium to the bloodstream via the lymphatics and venous circulation. The first one, the transepithelial flow fluid, is rapid, while the second process going to the blood, in lymphatic circulation, is a little bit slower. And so this data from rabbits shows that this process may take several hours. And therefore, when you have a baby with TTN or transient tachypnea of the newborn, the longer for babies to resolve the symptoms is based on how much fluid they have and how fast this lung fluid clearance occurs. Okay? The pulmonary blood flow increases with the start of air breathing after the baby is born. We'll squeeze some of that fluid out. But the lung water, which is in the interstitium, does not begin to decrease until about 30 minutes to 60 minutes after birth. So if you go to a delivery and you have a full-term baby with tachypnea, wet lung, don't judge the baby to be sick right away, especially if there are no risk factors for infection, sepsis, etc. We just observe these babies. After 4 to 6 hours, which is the time I allow for transition period to occur, will I declare that the baby probably has more than just being a TTN and probably has more disease than TTN if this does not resolve in that period of time, or if it's not improving. Okay, so air inflation shifts residual liquid from the lung lumen into the distensible perivascular spaces around large pulmonary blood vessel and airways, where this pulmonary blood vessel will be your exit strategy for this liquid to go. Okay, this is more of the same, and this is just micrographs of how fluid are shifted. Again, part of the summary is the pathways for removal of fetal lung fluid is where the potential routes of lung fluid drainage at birth happen. So there are 4. One is when they get into the interstitium, the lung lymphatic drainage will kick in, contributing to this much percentage of lung fluid clearance. The other is the pulmonary circulation, where most of the drainage occur after birth. You know, that's why those venous drainage are critical in modulating this transient tachypnea of the newborn. The mediastinum or pleural space contributes very small. It's a minor contribution. And then the upper airway, where we discussed earlier during labor and the vaginal squeeze during delivery, okay, um, it does not explain the whole thing. It's mostly the pulmonary mechanics, the physiology of production and clearance of fluid via those chloride and sodium channels. Okay, so what happens if there is persistent postnatal pulmonary fluid, or what we call edema? In full-term babies, this is the phenomenon we call transient tachypnea of the newborn. Okay, in preterm, because they don't have enough of these maturational components, they have much more delayed fetal lung fluid removal, and that contributes to the degree of their respiratory distress. So in preterms, they have impaired pump activity in the epithelial cells, and the filtration pressure in the pulmonary circulation is high, so it doesn't occur smoothly. And then the plasma protein oncotic pressure, osmotic pressure contribution is not is low, and all of this will affect the preterm. Okay, we normally don't call preterm babies as having TTN because they're preemie. We call them as having premature lung disease or respiratory distress syndrome or surfactant deficiency, because it goes hand in hand with delayed clearance of pulmonary fluid. But in full-term babies who have enough surfactant, okay, and went through delivery without trial of labor, we know for a fact that animal studies have shown that these babies just have a lot of lung fluid, and therefore the TTN diagnosis is warranted. But we don't just label them as TTN right away. We want to make sure that there are no other diagnoses that may complicate this picture. Okay, so this brings us to the discussion of transient tachypnea of the newborn, which you will see a lot when where I work. You know, our RTs, they pretty much run the labor and delivery airway management along with our nurses, and then they only call us, the neonatologists, if they get into trouble. So you make sure you know the physiology of this, and you can handle these babies in the delivery room. Okay, so this postnatal clearance of fetal lung fluid in the air spaces, I showed you the protein is very little. It has no protein. Okay, and then the transepithelial osmotic pressure is also very different. So we already pretty much went over the summary. What I would like to do is go over, oh, sorry, I failed to mention that this particular diagram explains the reversal of the clearance of fluid. So this time, this chloride pump that used to go in this direction, now it's the sodium pump that goes in the reverse. So fluid in the potential airspace will now go into the lymphatics, and then from the lymphatics, go into the microcirculation or sometimes pulmonary pressure. And this all contribute altogether in clearance of lung fluid. So you prevent TTN from happening. Okay, so clinically, what is transient tachypnea of the newborn? Okay, I will say it is probably a diagnosis of exclusion. You want to rule out other things that may present with respiratory distress. Okay, so TTN is a presentation in babies with some respiratory distress. They're tachypnic within the first 6 hours after birth. They may have mild retractions. They may have mild cyanosis, or sometimes more cyanosis, the higher the degree of fetal lung fluid still retained. They may or may not grunt. All you see is a baby who's breathing very fast. They may or may not be able to maintain their color. That's why I said there's some of them may present with mild cyanosis and may need extra oxygen. Okay, it's a mild self-limiting disease. It's often seen in term babies or in late preterm. Like as I've said earlier, in the preterm ones, You often think of pulmonary immaturity as opposed to TTN, although TTN can complicate pulmonary lung disease. Okay, so the tachypnea is evident because you cannot feed babies who are tachypnic. They breathe like 60, 80, 100, even more than 100 per minute. And they're like not in terrible distress. They may have some nasal flaring, they may have some mild retractions, but the degree of their tachypnea does not correlate much from how bad or how poorly the lungs are wet. But I'll show you some examples of x-rays later. You can still see here good air entry because the anatomy is mature, but you see crackles or rales as a result of this retention of fluid, okay? The ABG may show mild hypoxemia, and this may be from babies who will present with mild cyanosis. Oftentimes, the ABG is normal because they breathe so fast, they don't retain much CO2, but when they do, it's a reflection of how severe their TTN is. They may require supplemental oxygen, but in general, it's 40 tops. My cutoff is 30, but any baby who requires more than 40, 50% probably has more than just TTN. So X-ray is really necessary to rule out A, whether you have a pneumothorax, B, whether you have other pulmonary disease, whether you have pneumonia, whether you have an undiagnosed diaphragmatic hernia, or some other pulmonary conditions like cystic lung, cystic adenomatous malformation. So before you can say it's TTN, you have to have a chest X-ray to rule out all the other diagnoses, okay? Respiratory failure is rare. It's rare to intubate babies with TTN. If they get intubated, they probably have more than just TTN, okay? And wet lung complicates their problems, okay? It usually resolves within 12 to 24 hours, but can last up to 2 to 3 days. The longer it lasts, the more severe the fluid retention is, okay? So the sooner the baby resolves, it correlates with how little lung fluid is still remaining in those lungs. So there's a direct correlation with the degree of lung fluid and how fast their symptomatology resolved, okay? So the pathophysiologic mechanism here is delayed fetal lung fluid absorption, okay? And when you do an X-ray, you see some bronchovascular spaces, peribronchial lymphatics. Some of the fluid are still there waiting to be cleared. There could be air trapping or hyperinflation due to the compression and bronchiolar collapse, okay? So some of the edema fluid will prevent some of the exhaled air to go smoothly. So it's not unusual to see a little bit of a hyperinflation or air trapping. The lung compliance is decreased because they're wet, okay? And this leads to respiratory distress and increased work of breathing. As I described, the tachypnea and the retractions. The tachypnea predominates more over the retractions, but they can both happen, okay? The risk factors for TTN are precipitous birth. If mom didn't go through labor longer. So the longer the labor, the longer the time for lung fluid clearance to happen, okay? That's why when you go to a C-section delivery, always ask, let's say, oh, it's a scheduled C-section. Or ask the obstetrician whether there was labor. If there's no trial of labor, you have to be ready that this baby may go through a TTN phase, okay? So in C-section delivery without labor, there's this impaired lung fluid clearance as we discussed earlier, and the chest was not subjected to the same pressure as in a vaginal squeeze during vaginal birth. So it's a double whammy, okay? So it's predictable. I can almost say that, okay, mom is having a C-section, late preterm, no labor, be prepared that this baby will have some respiratory symptoms and be ready to supplement oxygen during your resuscitation. So these have been studied, the effects of C-section on lung mechanics and lung volume, okay? If you look at the gas volume, in SVD, spontaneous vaginal delivery versus C-section, The lung volume of the vaginal delivery is way more than the C-section, 32 versus 19, okay? Although the chest circumference is the same in both. You know, the chest circumference doesn't really help you determine whether there's more thoracic gas in this vaginal delivery versus your C-section. So the conclusion of this study shows that the C-section infants have high volumes of interstitial and alveolar fluid, but decreased thoracic gas volume, okay? And when they look at, in another study looking at FRC, it failed to show a higher FRC in vaginally delivered infants compared to elective C-section. Other risk factors, delayed cord clamping. The contribution of this is just you're contributing more volume of blood towards the baby. And that might be more venous congestion as a result. And this could be transient, that they may be tachypnic because they have a lot more blood volume circulating and maybe thicker blood, okay? There are positives and negatives of delayed cord clamping, but this is considered risk factor for TTN. Male gender, somehow in neonates, in neonatology, the male seems to be more disadvantaged compared to the female, okay? Macrosomic baby, large babies. And probably these macrosomic babies are infants of diabetic moms, particularly moms who are not diagnosed to be diabetic. They have delayed clearance, delayed maturation of lungs. Multiple gestations, twins, triplets, okay? They're kind of like cramped in that uterine space. Asthmatic moms who are treated with medications may have delayed lung fluid clearance, the babies, okay? And then there's a few associations, but they're less consistent, meaning excessive sedation. If mom received mag sulfate, for example, and the baby is a little bit drowsy, you know, will that affect lung expansion during breathing? So excessive sedation on the part of mom may affect the baby's state of sedation, and therefore may not have a good cry at birth that will help propel some of that lung fluid clearance. Prolonged labor, meaning how prolonged, is long, prolonged labor, meaning is there enough or overwhelmingly, will extended long labor prevent TTN? We know statistically that it helps, but how long is long is a matter of, they don't do studies looking at, oh, let's do 12 hours labor versus 24 hours of labor and compare that to like a 6 hour of labor. But all we know is that in precipitous delivery, when babies are born too fast, there's not enough exposure to labor to help them clear their lung fluid, okay? And then less associated risk factor is if mom receive a bolus of fluid, will that affect more fluid going into the baby? That hasn't been consistently shown to be so, because there's the placenta that kind of protects volume overload to the fetus, okay? All right, so what other conditions may mimic a TTN baby? Like as I've said earlier, there could be pneumonia, okay? Sepsis, if mom has chorioamnionitis, for example. Or this could be a baby that's more premature than they thought and has surfactant deficiency or RDS. Could be a cardiac lesion, although most cardiac babies don't present with this degree of severity of respiratory distress very early because the duct is still open and they may remain pink, okay? Central, I think this is hypoventilation. Sorry, this is a typo. Central hypoventilation syndrome. And others include pulmonary hypertension, meconium aspiration, or polycythemia, you know, thick blood, like in delayed cord clamping, for example, okay? One word about meconium aspiration. Some of these babies may present with respiratory distress and we think they have aspiration, but in reality, they may have TTN more than true aspiration because they're especially during the time when NRP, we were intubating babies and clearing their airway before PPV, okay? Nowadays, NRP is just one pathway for managing babies with meconium stain amniotic fluid. So we're seeing less and less of that, okay? Pneumonia may have, like interstitial pneumonia, may have a different or may have a similar picture with TTN on a chest X-ray. So how do we evaluate and manage these babies? Well, we don't feed them. They're NPO because they may risk aspiration if we feed them. They're breathing fast. They're not interested in POing. We manage them with fluids. Fluid restriction is not really the key, okay? Then we work them up. Lab works to rule out sepsis, rule out hypoxemia. So we do a CBC with differential, a blood gas, a blood culture. We may or may not start antibiotics if the suspicion for infection is low. Although the dictum is if a baby is sick looking, it's septic until proven otherwise. But we all have seen many times that, especially cesarean section delivery, tachypnic babies, they look sick because they're breathing fast. We do blood culture. We hold off on antibiotics because we don't want to give too much antibiotics unnecessarily to babies. And of course, we look at the chest X-ray, okay, to rule out all the other differential diagnoses. This is a classic picture of a TTN baby. If you notice, there's some perihilar streaks coming from the hilum towards the periphery, okay? You see this thick line here that it's the fissure, minor fissure of the lung. There's some fluid there, okay? And then the angles here are not very sharp. Also, and this is usually bilateral, homogeneous, meaning you cannot just have TTN on one lung, okay? If you notice the expansion of this lung is not that much, 1, 2, 3, 4, 5, 6, 7, 7.5 to 8 ribs. Most TTN babies will have maybe like 9 or even 10 because they may have hyperinflation, but it's not always the case that they have hyperinflation. So the characteristics findings on X-ray are these perihilar streaks, which I just described to you, okay? The heart may look a little bit big. There are some densities that may lead to periphery, meaning there's some fluid-filled alveoli, and then the fluid in the minor fissure that in the pleural space that I mentioned, and some babies may have a hyperinflation, okay? These X-ray findings will clear within 48 hours or sooner, especially if you're providing respiratory support, like if you're giving positive pressure, like CPAP, okay, or NIMV. This is an X-ray which is a little bit more fluid-filled lung. You can see that the heart is not even well delineated. You still see this fluid in the fissure and some haziness on both upper and towards the periphery if you look at these streaks from the hilum this way, okay? So the degree of, if this baby didn't have any CPAP or just, room air or oxyhood, for example, or cannula, you may not have good lung expansion because some cannulas may provide a little bit of a CPAP effect. This is a TTN baby too. See this interlobar fissure here, this white line here, okay? A little bit hyperinflated because the lung part here is a little bit dark, but you can still see the streak coming from the hilum towards the periphery, okay? The respiratory support may need to be escalated in some babies, meaning you can give oxygen via nasal cannula or CPAP or NIMV. But as I've said, if the baby requires intubation, you're probably dealing with more than just a TTN, okay? The use of antibiotic may be started, especially in the setting of infection on the part of the mom, like PPROM, sorry, there's another O here supposed to be, premature prolonged rupture of membrane, if mom had a fever, if mom is GBS positive, for example, because GBS pneumonitis may not be distinguishable from that of TTN picture. And we stop the antibiotics 36 to 48 hours with the negative culture. Randomized controlled trials have shown that because people have thought if the lungs are wet, if I give diuretics like Lasix will help. Studies have shown that whether you give orally Lasix or IV Lasix, that there's no effect on the clinical course of TTN, because the fluid, you cannot force the fluid to from the lung to be cleared until the fluid gets into the vascular space, okay? So the idea is to squeeze this lung fluid into the bloodstream, and that's when Lasix will work, okay? Because Lasix is systemic, it doesn't work in edematous babies unless the fluid shifts, goes into the vascular compartment. And the prognosis is pretty good. You know, it's self-limiting disease. There's no risk of recurrence because as you clear lung fluid, there's improvement in pulmonary circulation, okay? And also some have questioned whether babies who had TTN early on will develop asthma later on. I mean, this has been floated many, many times using case control studies or cohort of babies. But what they really have concluded is that TTN is a marker of deficient pulmonary function, meaning how delayed the lung liquid clearance will happen that might affect or predict their inherited susceptibility to asthma in the future. It's a big question mark. I'm not going to put my money and say there's a link between TTN and childhood asthma, but it's been questioned before. So I think the answer here is no, there's no correlation. With that, I end my talk. I have about 10 minutes for you guys to ask questions if you have any. Okay?